afternoon, everyone. So we welcome everyone to the next section of the ART and comorbidity. So this is, I think, is important workshop for everyone, especially adult living with HIV. So we have very good program and good cases, and also we have a very good panelist for you to ask them or to have a question. So just feel free to come out. So just right to start. So my name is Dr. Anjali Avihingsanon from the HIV-NAT Thyroid Cause AIDS Research Center. First, I would like to introduce my co-chair, Associate Professor Julirat Bawanwatanwong. She is President of Thai AIDS Society, and she has very extensive experience in taking care of HIV in Thailand since at the beginning of this era in Thailand. So the second panelist, so Dr. Iskandar Aswar. He is an associate professor of infectious disease at the University of Malaya, Kuala Lumpur, and Malaysia. And he is the current president of the Malaysian AIDS Council. And he is very expert in PrEP program, right? And very active, involved in like implementing PrEP program in Malaysia. And the next panelist, Professor Gail Matthews. She is a professor of infectious disease and also lead the program head of therapeutic vaccine and research program from Kirby Institute, Sydney, Australia. And the next panelist is my favorite, yes. So Professor David Berger. He's from the hospital, pharmacist, clinical pharmacologist, and professor of clinical pharmacology, Radboud University from Nijmegen. So he's very expert in all the drug interaction. So for today is a good opportunity for everyone to ask him any question on drug interaction. So from A to Z, right? From HIV up until hepatitis C co-infection. The last panelist, so Professor Pranjan Cheshotisak. So she is a professor of medicine and from the Division of Infectious Disease and Tropical Medicine, Department of Medicine, Srinagar Hospital and Khon Kaen University. So unfortunately, she cannot join us as in person. So she will be joining us via Zoom. So any question also. So today is very good opportunity for everyone who have the question on the HIV care. So I would like to start with the first case. So we're gonna swap first. Case 1 and case 2, and then swap because of one of panelists, Professor Gail Matthew, need to leave early. So any question on the hepatitis or hepatology, so just direct to her from now. So just would like to invite Ajahn Turiras to present the case number 1. So thank you very much.
Good afternoon, everyone. This is a session of the round table. I put the title is for my session is a chair practice, dolutegravir. And firstly, I would like to acknowledge HIV-NAT Organizing Committee. My hospital, I work in the public hospital in the eastern part of the country, Chonburi, Banglamung, Rayong, and Trat Hospital. And the last is all of my patients will permit the clinical for the presentation. Just last Tuesday, Dr. Anjali phoned me that it is possible for me to prepare the case of the dolutegravir. At that time, I'm really busy and I could not commit her on that moment. But anyhow, on the following day is my clinic day in a Wednesday in Chonburi Hospital. Just only one day, I met I faced with the problem of dolutegravir, so I accept her invitation that, okay, I will share the practice with the dolutegravir. I think in this room, everyone knows that we have the rapid development of the ART since the mid-1990. But after 2007, there is a new class of the integrase strand transfer inhibitor, start with the raltegravir in 2007, and then with the dolutegravir in the 2012, and our main drug today is dolutegravir in the 2013, and bictegravir in 2018. Everyone in this room know that current guideline of DSS guideline or even to the WHO mostly focus first line on the dolutegravir. And in Thailand also in 2020, we also put the dolutegravir as a third drug in the first line recommended drug. So I think that in Thailand, we have nearly 400,000 people on the ARV, and mostly on the first line drug with the combination of TTC, tenofovir, and efavirenz base. So we make a decision to transition of the efavirenz base to TLD. So this is TLD, dolutegravir in Thailand. We have the separate tablet in the 50 milligram pill. And we also have the combination of TLD with the tenofovir, TTC, and dolutegravir. So we will learn this afternoon about the undesirable effects of the dolutegravir that I will present you by the case of my patient last Wednesday. Only last Wednesday that I met. I prepare with the skin reaction, renal, hepatic, and weight gain. But we will start with the hepatic involvement. So when dolutegravir launches, Glaxo or big company that have the developed program called the DTG development program. We include the population totally is 1.5 thousand cases with the comparator of with the efavirenz, with the PI like atazanavir. So it's prepared separate into two groups. The group one is ART naive, which is everyone know that about the spring study, spring 2 single and Feminger, and art experience with the INSTI naive in the selling. So we have the comparative. So from the DTG development program, we will learn that I would pass to the case 3 first, because we will start with the case 3 about the liver. My patient last Wednesday, he is 48 years old, was diagnosed in the 2001. That means it's 20 years ago. Of course, he was treated with the AZT, DDI, D4T, something like that. Anyhow, he's a very good compliant patient. And the last 5-year history, you can see that in 2017, his body weight is 83 kilo, and viral load undetectable. At that time, of course, he passed since the beginning, so he's on the salvage regimen with the teno-EM, TTC, tenofovir, and lopinavir. The creatinine is quite good. The SGPT is okay. So he was on this regimen until the 2019. And he has a problem of the rising of the creatinine up to 1.17. So we decided to change the teno-EM. That means the TTC and tenofovir to be the Kivexa. That is the TTC and abacavir. to alleviate of the creatinine high level. And of course, the third drug still be on lopinavir, which is the cheapest PI in Thai practice. And he was on this regimen since 2019, 2 years past. Everything is to be all right, creatinine, liver function test. But in June, I told you that in Thailand, since June last year, we are in the transition period of the TLD and dolutegravir. So we have to be away from the PI and use the dolutegravir. So this man was changed of his regimen, Kivexa, lopinavir, to be the Kivexa and the DTG. After changing to DTG, and we follow up usually we follow up every 3 to 4 months if there is no problem. His creatinine is rising from 1.15, the SGPT up from 14 to 132. He has no symptom at all. So on last September, I think okay, it may be from any kind that not serious. So we follow up him again last Wednesday. This is his picture last Wednesday. His liver function test still high of the SGPT as 125. Alkaline phosphatase is okay. And SBS antigen is negative, and also HCV is negative. So my first question to the audience that will you move away from the DTG, yes or no?
So everyone can scan QR code here, the attached with your document, and you can vote from there. So for this room, it's a ballroom. So here.
Sorry.
Yeah. So
okay. I just test. Okay.
Okay. Just scan and vote. Yeah.
Okay, that's what. The first one is we move away from the DTG, and B group is no, and the YC, I have no. Okay, may I ask the panelists of the comment of this case?
So Gail, you want to be first?
Yeah, this is on, I think. Okay, so actually, I would disagree with the majority of participants at this stage anyway. I mean, I see a lot of, or get referred because I have an interest in viral hepatitis and hepatology, a lot of patients with HIV co-infection. Firstly, I guess I would ask myself, is there any urgent need to switch him off the dolutegravir? And I think the SGPT is what we would call an ALT. Yeah. So it's an ALT rise of between 5 to 10 times maybe upper limit of normal. If your upper limit of normal is around 30, is that right? Just under 5 times. I'd be interested to know what his bilirubin is, because with a drug-induced liver injury, a DILI, one of the things we worry about with Hy's law is if the bilirubin's rising. That's a real sign that somebody's in danger and you need to take them off the drug quickly. So one of the things I'd like to know is obviously what his bilirubin is, and providing that's normal and everything else is relatively normal as is shown there. I would also, before I take him off the dolutegravir, I would like to try and understand what is the cause of his liver function rise. So there are many, obviously, causes of asymptomatic elevation in LFTs. Viral hepatitis, obviously, is one of the main ones. And I was interested to see that he'd switched off, he didn't tell us his hepatitis B status. I presume here in Thailand where background hepatitis
negative.
B, it's
we already tested.
Oh, you have got it there, yes, good. I was going to say because he went from tenofovir to Kivexa, so 3TC resistance in somebody who's got unidentified background hep B can cause a liver function rise. Acute hepatitis C can also cause a liver function rise, and he's got no risk factors.
We already checked negative for hep C.
Negative for hep C. I'm interested if he's taken any other over-the-counter medication.
Yeah, yeah.
You know, any paracetamol or any Chinese herbal medication or any other medication to make sure that he hasn't taken anything else. And then I'd be saying, well, if you've excluded all other causes, then is this a function of weight gain? So has he gained a lot of weight with the dolutegravir? And is it actually a bit of fatty liver?
It's stable. The weight gain only 1 kilo after we change from the lopinavir. It's stable for 84.
Okay. And has he had a liver ultrasound?
Not yet. Just the last week that we had it.
So, you know, even if he has had weight gain, fatty liver is still a cause of liver function abnormalities, transaminitis. And so I'd be looking to address those things before switching him off the dolutegravir straight away.
So Gail will be not yet to change the dolutegravir. The patient, after he know his result, he asked for the previous, resume back to the previous regimen. So I would like to share the practice with the audience. Any comment or idea, or even David, please.
Yes. Yeah, so I think Gail already mentioned the most important aspects. I can only add two further comments. That indeed this is something we do see, not very often, but sometimes we do see it. Most of the times people have changed more than one drug, so they started with Triumeq, for instance, and then you're not sure whether it's a dolutegravir or the abacavir or any other agent. So that's here you only change one drug, so that makes it a little bit easier, but sometimes you change more medications and you're not sure which of the drugs might be the cause of the liver enzyme elevations. And the second aspect I think is very important to rule out any other causes. I remember a patient a few years ago who switched from the innovator drug to a generic drug. And then 1 week later, the liver enzymes went up. Well, that's something you don't expect that to happen because it's the same medication and, okay, there can be some changes in excipients, but that really the enzymes, the liver enzymes go up. But everybody was so afraid, and also the patient, of course, so he went back to the innovator drug. And then 2 weeks later, it turned out he had hepatitis A infection, which, of course, explained his liver enzyme elevation. So nothing to do with the generic substitution. But I think that it's likely that both patients and doctors are afraid after you switch a medication and you see something happening, that there's a causal relationship. But maybe, but also maybe not. Yeah.
Okay, you will still be on the dolutegravir and
I would
find
follow.
other cause.
I would follow the advice that Gail was giving. First, rule out any other causes before you stop. It is also about what are the options. So that's another problem we have. So I also would expect in our situations that if you have other options, maybe doctors want to go to another combination because they have the option. If you have fewer options, then you don't have that luxury.
Last Wednesday, I tried to ask my patient about any new drugs, any new substance he takes. The answer is no. He has no symptom at all. The bilirubin is still in normal. Okay, please.
So if I could just add, concur completely with everything that's been said, but also just maybe ask for risk factors for STI, and if the hepatitis C antibody was negative, then maybe if there's a strong suspicion of acute hepatitis C, maybe do a hepatitis C RNA. For completion, I probably would do syphilis serology as well, although that presents predominantly as a cholestasis with a disproportionate increase in alkaline phosphatase. But really, I think I would be also of the same opinion. I probably would just watch and monitor very carefully in the meantime as well.
Okay. Any comment or idea from please feel free to share the practice. Go to the microphone and identify yourself. We prepare the present for the commentator on the floor. Not yet. So from my idea, the increase of the SGPT up to 10 times, right? 14 to 132, not the point, right? If they are still asymptomatic and bilirubin is still normal. So even we can accept up to 5 times of the abnormal limit, that means 40, that means 5 times is allowed 200, right? So maybe we have to work up to find the cause of the elevation of the SGPT. If we search of the cause and nothing be the cause, will we accept to, or we will follow up him next 3 months or 4 months if he have no symptom? And at what level that we consider to move away from the dolutegravir? Because my patient, he asked, please, doctor, I prefer the previous regimen. After he know the result of his liver, because his liver is almost always normal for 10 years.
I think one of the things to think about with liver function tests is we do worry about them, but we have to remember that an ALT of 130, as long as it's not rapidly rising, and as long as the bilirubin is normal, is tolerated for a long period of time. So what we worry about is that level of liver function abnormality over some period of time, inducing fibrosis for whatever cause, whether it's fat or whether it's drugs or so on. So I think there's no urgency to move him off, but so you could follow him. You could just follow him with repeated liver function tests over a period of 6 to 12 months, providing it wasn't rising rapidly. But if you have got drugs to go back to that he prefers, that's also possible as well. So I do think we tend to worry a little bit too much about what is not a very high elevation in liver function tests. It's not going to immediately cause the patient harm, probably.
Okay. So if we follow the suggestion, we search for the cause. If negative, we can sit tight for another 3 months. That means totally 6 months to see the number. If there are no symptom and the number is stay around 100 plus, you continue the dolutegravir, right?
Yeah, I think it's the trajectory of the rise. So certainly in somebody who's gone from normal to that level in a relatively short period of time, I can't remember the time, I think you'd want to check it again pretty quickly to make sure it wasn't next going to be 500 in another few weeks and there was something, acute going on. Okay. But if it's really been very slow rising and is sitting at around this level, then I don't think there's any immediate urgency, all else considered, to take him off the drug. But if you have other options, a bit like David said, if you have other options, you can switch into something else, and you can also then see if that causes the liver function test to reduce.
Okay. So from that, I told you that Glaxo or VIP company have reviewed about the dolutegravir side effect in that DTG development program about the grade 2 to grade 4 higher increased liver enzyme for the dolutegravir user usually occur in the co-infected patients, Hep B and Hep C co-infected. So the first thing that we have to consider is whether our patient just infect with the Hep B or Hep C or not, to rule out the cause. And from this program, when they compare the toxicity of the liver enzyme lysine, the efavirenz and raltegravir is higher than the dolutegravir, and the dolutegravir is higher than the darunavir. So if we have to move away from DTG, will you suggest the use of the darunavir or other?
The question is if we want to move away from DTG, so which medication that can be used for this patient, whether it's darunavir or other drugs?
I think it largely depends on what's available to you and what the cost is to the patient.
Available lopinavir, the cheapest one.
So probably that might be the most sensible thing to switch back to the patient too. Although lopinavir is you know, it's not a really nice drug, right? It's got a high pill burden, it's got multiple side effects. I'm just wondering also, if you switch from, if you're considering raltegravir as an option, it may not necessarily, and if the liver, if the transaminitis is related to dolutegravir, it may not necessarily represent an in-class effect as well. So it may be permissive to also switch back to another class, to another drug within that class. I would have thought so, depending on what's available to you.
Any more comment in this case? Okay, this is one of my 4 cases. I will stop here and I will ask Win. He will present about the NASH of the hepatitis infection, and after that I will present the rest of my 3 cases.
So before Win present, I just like to ask Gail, so what the level of ALT elevation that you feel comfortable to continue that medication? And how about if this case, he diagnosed as a NASH or fatty liver disease, or if he has a underlying cirrhosis from NASH. So what the level of ALT that, yeah.
So I think it's, I mean, that's a hard question, but because it's not the absolute level, as I said, it's more also the trajectory. Certainly an ALT greater than 10 times the upper limit of normal. So whether it's 30 or 40, that would be 300 or 400. I would worry about that level of ALT, absolutely, over a sustained period of time. Even a few months in terms of its ability to cause damage. It really depends, though, what you think is causing the damage, and as you alluded to, whether the patient has underlying liver disease, because a patient with underlying cirrhosis will tolerate an ALT rise a lot less well than a patient who's got a normal healthy liver. And if you remember, when people have normal healthy livers, if they get an acute hepatitis B, for example, the ALT will go to 3,000, 4,000, and they recover, and that's fine. So it's not a permanent damage. So it's more about what's causing the ALT elevation, what level it is, and what the level of underlying fibrosis is. And that's why having either a FibroScan or some measure of the fibrosis score is also an important part of the liver workup. But certainly I would feel uncomfortable letting anybody go along with an ALT of 300 or 400 persistently, unless there was nothing else I could do about it. We switching drugs.
Okay, so how about if this case develop like a high bilirubin, and also let's say 5, and then have a high ALT, AST, so and he meet the criteria of drug-induced hepatotoxicity, any treatment that can help?
Stopping the drug.
Just stop the drug.
Yeah, I mean, I think that's one of the situations where, we talk about this, and we can't, not enough time to go into it now, and actually it's not my area of expertise completely, but there are different kinds of drug-related liver toxicity, and a sort of a slow irritation of the liver from a drug is very different from an acute drug reaction with an elevating bilirubin and really a toxic hepatitis, where you would want to stop the drug very quickly.
Steroid has a role. Steroid.
I mean, steroids are often used, aren't they? I think. Yeah. Yeah.
Okay, thank you
I'd
very
hand
much.
that over to a hepatologist. I'm not a hepatologist.
So thank you very much. So just move on to Win. So Win Min Han he's from Myanmar, but he's with us for more than 5 years, right, Win?
Yep.
Okay, and he is a PhD student from University of New South Wales, and he's gonna present us for some interesting case. So.
Right. Yeah. We probably have to let Gail go. So.
Oh yeah. So Gail is
Sure.
his mentor.
So I will start with 2 case discussion and then follow by epidemiology of NASH and also some of the data that we have in here in Bangkok on the cohort. So probably we'll start with 2 case discussion first. So the first case is the nephroid aging. So we got a 62 years old lady diagnosed with HIV since 2001, who was admitted hospital due to TB infection, of course, with a history of tuberculosis and received anti-TB treatment for drug-sensitive tuberculosis in 2001. And she experienced elevated liver enzymes, but were tolerable after desensitizing of the anti-TB drugs. So at the time, the DSCD4 was 189 and then having CDC stage C. There was no history of other drug allergies. Hep B, Hep C were negative, and there was no excessive alcohol consumption or other autoimmune disorder. And the current CD4 was 520, and with the viral suppression less than 50 copies per mil, and currently on TAF, FDC, and dolutegravir. But she experiences persistent elevation of the amylotransferases, however, having normal ALP, GGD, and her first fibrosis 4 score was 2.5, with creatinine clearance of 71 ml per minute. BMI was 23.2 kilogram per meter square, with the weight circumference and weight height ratio were in the normal ranges. And about the ERT history, so she started with stavudine, lamivudine, and nevirapine in 2001, and until 28, switched to zidovudine, lamivudine, and efavirenz. And then in 2013, ERT was switched to TDF, 3DC, and lopinavir, ritonavir boosted lopinavir due to NNRTI failure. And then in 2019 until now, she was on TAF, FDC, and DDG, which was switched from lopinavir because of intolerance. And after switching from DDG, she experienced weight gain about 3.2 kilo over 1.5 years. Regarding other comorbidities, there was impaired fasting blood glucose, but there was no threshold reaching the diabetes. The blood pressure were normal, however, having borderline LDL with triglyceride of 260 milligram per deciliter, which is approximately equal to 2.9 millimole per liter. And we also have the data on the transient elastography and then measure of liver stiffness with 4.4 in September 2017. And the latest result was 10.1 in October 2022, with the cap value to identify the liver fat was about 300. And then ultrasound abdomen showed fatty liver, but there were no focal lesion detected. So I got a few questions for you. The first one is, what other investigations are needed for this client? Would you repeat the transient elastography, including cap and liver stiffness in 6 months with platelets? Or would you assess for the cardiovascular risk, or for example, assessing 10-year ESCVD risk, or you would do both? Maybe we can vote, but the answer is kind of obvious. Thanks. So we got a high proportion of participants choosing C, but there was also a fair distribution of choosing 1 and 2. And I got second question for you all is how about ERT management? Do you think we should switch from TAF to TDF, or would you continue the same current ERT, which is TAF, FTC, and DDG? Or would you switch to DDG to NNRTI if there was no resistance? Awesome. Thank you for the answers. I probably will leave some of these questions to the panelists to discuss what they think about this case management.
Okay. You want to go first, Gail? Okay.
All right, so with the first question, so firstly, platelets are always useful to have, partly because they give you a a guide to whether a patient has portal hypertension. It's actually one of the easiest things to tell you whether a patient has portal hypertension, a platelet count under 100 or 90 to 100. The other thing is you can use a platelet count in an APRI score, and that gives you another measure of fibrosis. And I note that this patient's fibroscan has gone from normal to a score of 10 point something, which is F3, fibrosis level 3. So that's quite a significant rise if it's a true rise in the fibrosis score of this patient. So an APRI score and a FIB4 or something would be nice to obviously to understand that's a true rise. Cardiovascular risk. So if I had to rank them, I'd say cardiovascular risk assessment is most important in this patient. A repeat FibroScan. I mean, I don't tend to repeat FibroScans very often. I don't know that they give you that much help when you repeat them, unless you think that your first one is false for some reason. So I would certainly concentrate on a cardiovascular risk assessment because she has got a number of risk factors for cardiovascular disease. I can't remember exactly all of them, but I think she had hypertriglyceridemia, she's overweight, she's older, and probably has some insulin resistance. So cardiovascular risk assessment is important. With regard to the second question, I'd agree with the audience. I would continue the same ART and really focus on her modification of metabolic risk factors. She's got fatty liver, whether that's partly due to her ART, but also probably other issues, lifestyle, diet, etc. I would really be working with her very hard to focus on those and reduce her risk, cardiovascular risk and her fatty liver disease, but continue the same ART.
Thank you.
Thank you. David?
Yes, so I don't think I should say anything about the first question. I'm not a clinical doctor, so I think that was mentioned by Gil. I can say something about the second question. I think that we have seen many times a weight increase with the current treatments, including the integrase inhibitors, especially if there's also TAF added to the integrase inhibitor. It's very attractive to focus on these medications and to adapt the treatment, and also for the patient, because she doesn't have to change anything because it's all about the medication. And I don't think that's the true story. So indeed, to improve a healthy lifestyle, to increase exercise, etc. Especially in the COVID time, and when people stayed at home for much longer than they used to, that was an additional problem. They could not go to the gym, for instance. So all these factors contributed, I think, also to this problem. And I think we really have to stimulate patients to exercise more, to eat more healthy, in addition to, of course, evaluating the medications. But there's a risk of not talking to the patient about that and only looking at medication.
Thank you. Professor Iskander.
Just 2 points that I would like to concern is number one about the comorbidity. Have you asked about her familial history, about the diabetes or the dyslipidemia in her family? Yes or no?
That's a very interesting question and important question. We didn't have a data. Probably it happens in the year.
As a clinicians. And number two that I concern is that since 2019, after she changed to the TAF and dolutegravir, her weight gain is increased. Maybe that I'm quite worried that if she has no problem about her kidney, maybe I still remain on with the tenofovir other than the TAF. And also her ultrasound start have the fatty liver. So I think that on any the factor that can cause a liver problem, maybe we have to avoid.
Right. Thank you.
So what additional things I may add was, so she's got evidence of fatty liver disease with F3 disease with progression over 5 years. So you'd be a bit concerned about that. Now I think I'd probably, in terms of whether we repeat the the fibroscan, because there is F3 disease, I probably would repeat it in a year, repeat also the platelets as well. I think it's very tempting to want to switch medication, particularly because there is some data to show that TAF and INSTIs are associated with fibrosis progression in some cohorts, although there may be some confounding around that. But once again, I think the focus really has to be on the metabolic factors, as David, rightly so emphasized, on Mediterranean diet, calorie restriction, aerobic exercise. I think that's where your real focus should be on. Then the other issue around where I think I would consider a treatment switch is particularly if there was significant weight gain. Now, weight gain of 3.2 kilograms in 1.5 years, I'd really want to watch that. And if it's associated with increasing impact on the comorbidities. So if there's increasing glucose intolerance, your lipids are going a bit out of control, her health outcomes are deteriorating despite that, then there might be a role for switching, but it wouldn't be my first choice.
So I think it happened in 2019 during the COVID. So many people will gain weight during the COVID because of work from home. So when we discuss with the patient, you should adjust your lifestyle and diet. It's quite difficult. And they ask me, you should do it too, not just only me. So the patient just told.
The other sort of comment I want to make, it may not be so relevant in this case, she may be a little bit old, is also, but you should not forget about it, is in women around the time of menopause can also cause metabolic changes, insulin resistance, weight gain, etc. So I think it's something that often gets forgotten in women living with HIV, that we should look at hormonal factors that may be playing a part in this kind of presentation.
And maybe another comment to specify on the question, if you can go back, so to say, from TAF to TDF. So in our patient populations, we often have seen patients who were on TDF and then had a renal problem, and then they switched to TAF. So then normally you cannot go back to TDF. Right. Here you see in history that when the PI was changed to dolutegravir, also TDF was changed to TAF. So it's not stated that there was any problem with the TDF. On the other hand, I must say she is now 62 years old, so even if you go back to TDF, then you have to follow up renal function, and maybe you are forced to stop TDF in a few years from now. So if you do it, you may not be able to continue it maybe for a very long period. So a backup plan for that is needed anyway. Yeah.
So I would like to ask David. As we know that boosted lopinavir increased the tenofovir concentration and resulting higher renal toxicity. How about dolutegravir and tenofovir?
No, that's a very good question, Anjali, and I think that a lot of the concern about the renal dysfunction with TDF comes from studies, clinical trials and cohorts where the drug was initially mostly used with boosted PIs. And boosted PI increases tenofovir levels if you give TDF with about 30%. So that's quite an increase that may cause toxicity in some patients. And if you really look at especially the clinical trials, but also the cohort data from Africa, for instance, where people have used TDF, and I think also here in Asia, TDF with an integrase inhibitor, you don't see the same incidence of renal function problems. Usually these patients are relatively young, so the question is what is going to happen when they become older, as we heard just in the lunch symposium. So it might be true that also after prolonged treatment of TDF with an integrase inhibitor, even if you don't see this increase in tenofovir levels, which is not happening with an integrase, there still might be some cumulative toxicity.
That short comment, one idea just popped up. He might be the candidate of the two drugs, of the 3TC and the dolutegravir, yep, if we want to be away from the TAF and if she had no HBV co-infection.
If I could add also, I mean, and maybe it's a question to the panel as well. I mean, because she's got F3 disease, she's at risk of severe fibrosis, whether pharmacotherapy would be considered at this stage, depending on what's available, you know, at your center, and whether the evidence is there to back up the role of these agents, you know, glitazones and vitamin E, for example. What do you think?
I have to say, in our context, and well, there's problems with it at the moment, but certainly in our high-income context, what is working for a lot of our patients, particularly the diabetic patients, is the GLP-1 agonist, so semaglutide. We can't get hold of it at the moment because of the worldwide shortage, but that is the only thing that I have found, apart from diet and exercise, and I always very strongly try and get patients to do the lifestyle modifications as well. But semaglutide, Ozempic, does result in a significant weight loss in these patients and can improve their diabetes and their fatty livers at the same time. But we don't use the glitazones or vitamin E in our practice.
No, and we do neither. And we also have a problem with a limit in access to the medication. So there's a maximum number of patients that can be treated. And then these patients usually have to have a much higher BMI, for instance, to become candidates for the treatment. So I don't think that in this particular patients we would find any medications for that, no.
Yeah, thank you. I think this is a very important discussion that we will be encountering in everyday clinics for the HIV care settings. With that, I would like to invite, if there's any comments from the audience, would like to share if your experiences regarding, you know, seeing similar situations. If you're there, please come up to the microphone and tell and share some of your experiences. Okay, maybe audience is a bit shy. So I think I will skip that question. Is that I think some of these are already been discussed by the panelists. Is that we should suggest the clients to get lifestyle modification, some weight loss advice, and also the cardiovascular reduction, such as exercise and a lot of other activities. With that, I will move to the second case. So this is a case on a fully in the person living with HIV with Hep B co-infection. So a 44 years old male client, HIV was diagnosed in 2015. There was no prior AIDS-defining illness, and HBV hepatitis B was diagnosed at the same time with HIV. BMI was 24.5 with stable CD4, and HIV virus suppression was achieved, having good ART adherence. There was no history of treatment failure. But he is a current smoker, social drinking, but there was no substance use. Fatty liver was identified through his routine yearly ultrasound abdomen. Remember, he has Hep B, so he got ultrasound every year for ACC screening in 2020. The latest liver stiffness measurement was done in 2021 January, was 13.2. There was no data regarding the fat content of the liver, but there were no other comorbidities such as diabetes, hypertension, but there was this lipidemia was noted from his lab work stuff. So the ART history from 2015 to 2020, the client was on TDF, FTC, and efavirenz, and then switched to TDF, FTC, and DTG, but with no history of treatment failure. So the question regarding this client would include, the first one is what other investigation needed? Do we need cardiovascular risk assessment? Do we need transient elastography every 6 or 12 months? And do we also need the HCC surveillance or all of the above? I think I will probably let the audience to answer these questions. Awesome. So we got a lot of participants choosing number A, which is cardiovascular assessment was needed. And there was also some feedback from the audience that we should continue to do surveillance hepatocellular carcinoma. And the second question is, how about the ERT management? Should we continue the same ERT, or we could switch to beta-carbier, FTC, and TAF? Because we know recently from the data that presented last year, but Dr. Anchali in ACE 2022, is that with the TAF, FTC, and beta-carbier, Hep B viral suppression was greater than the control group, or do you consider switch back to NNRTI, which is riverine containing regimen? Could you vote for that? Great. So with that, I'd like to leave the discussion to the panelists regarding the question 1 and 2. Is there any recommendation or suggestions or any feedbacks from you? Thanks.
Okay. Who want to be first? Gail again?
All right. Okay, so my main worry with this guy is that he's 44 and he's got cirrhosis by the looks of it, basically, on this FibroScan. So if you take a cut-off for cirrhosis at 12, 13, so he's young and he's got cirrhosis. So we don't know why that is. We don't know whether it's, whether he had a lot of damage in the past from having Hep B for a long period of time. So I'd like to know a bit more about his Hep B. I presume his Hep B viral load is undetectable.
Yep, it was suppressed.
Yeah, and is he maybe E antigen negative and right. So on. Make sure he hasn't got Delta, make sure he hasn't got anything else. When he says social drinking, that worries me in the context of somebody who's got cirrhosis. He shouldn't be drinking at all. So you need to encourage him to have no alcohol. And then if we're left with fatty liver as a cause, or NASH as a cause of his cirrhosis. And actually, in some cases like this, I do consider a liver biopsy, because I think it's really important in a young person to know why they have cirrhosis. He may have some other more esoteric causes of liver disease, that we can't go into here, but autoimmune hepatitis or one of the genetic conditions. Anyway, if we assume it's his fatty liver or his NASH, then he does need HCC surveillance, so that would be 6 monthly ultrasounds, actually, not yearly. I'd be bringing him for an ultrasound 6 monthly. He fits the criteria for that, and then very strictly controlling his hyperlipidemia and trying to get him to reduce weight, because his BMI is 24.5, so he probably is a bit overweight. So I'll be trying to bring that down as well. Whether you change his ART, in this situation, I might think about it if I was convinced there was no real other good cause for his fatty liver and we thought it was potentially dolutegravir induced, and you could certainly go back to rilpivirine, but I might try and address all those other things first.
Yep. I do agree this is a good indication for the liver biopsy for these patients. So, yep.
My concern this case more than the first case. First is so young, 44 years when compared to my age. And the second, he's a HBV positive, right?
Yep.
And he still drink. So what I'm concerned is about the HBV status. Have you evaluated his HBV status? Complete suppress or
Yep, HBV DNA was suppressed.
suppress?
Yes.
Okay.
David, do you have any suggestions for the ART?
So I think there's no urgent reason to change any of his medication, because that's not giving us the biggest problem, and he's suppressed. And if it's TLD, maybe it's a single tablet regimen, so that's attractive, of course, for adherence. I could imagine that maybe he now is on DGG for 2 years or so. If there would be a weight increase despite all the other recommendations, then you certainly don't want to have it here. And instead of going to rilpivirine in our center country, we have the availability of doravirine. And that is a more attractive non-nucleoside to me, because there's no need for food intake with the medication, and you don't have the drug interaction with the acid-reducing agents, which many patients take. So instead of rilpivirine, we rather would recommend doravirine Although I must say that the data are showing that if you change from an INSTI to a non-leukocyte, because of, let's say, weight increase, that's well, the follow-up may be too short to really see major changes. So that contributes to the discussion we already had about the lifestyle, etc., and other causes for weight increase other than medication alone.
Yep. Thank you.
So I would do A, B, and C. And I would also look for, because he's cirrhotic, I would also look for evidence of portal hypertension and esophageal varices. I probably wouldn't switch his treatment. I still probably would continue his treatment until evidence sort of emerges that if you switch treatment, that it does improve or show improved fibrosis with progression. I would once again reiterate the metabolics and control of that. And if he fits, and if he fits the criteria for bariatric surgery, I may consider that. I think that's often overlooked or underlooked. So maybe include that in part of the discussion. And maybe here pharmacotherapy could be considered in this case, and statins only if there's coexistent dyslipidemia.
Yep, thank you. Potentially, would you like to discuss about beta-carbier, or we have to have?
Oh, I think I would do the same with
Right.
Iskandar. So, and also BMI, just only 24. Actually, it's less than me. So maybe just discuss with the patient whether he can modify his lifestyle, especially alcohol. It's a high calorie for like if he drink beer or something. So it's high carbohydrates as well. So.
So with that, I'll probably will move to a bit of a discussion on the epidemiology and then some of the data in here, Bangkok, Thailand, regarding the HIV and NASH. So this will be the contents of the following slides, and I don't have any conflicts of interest to display. So we all know that NAFLD is a spectrum of liver disease ranging from steatosis to NASH, which is non-alcoholic steatohepatitis, followed by liver fibrosis, cirrhosis, and hepatocellular carcinoma. Globally, NAFLD affects 25 to 33% of adults in the general population. So major public health burden because it's associated with cardiovascular diseases, metabolic syndrome, diabetes, and also liver-related or all-cause mortality. And also, NAFLD is the fastest growing indication for liver transplantation in high-income countries, for example, in the United States. And its pathophysiology is kind of complicated, often associated with obesity, metabolic dysfunction, although the prevalence of NAFLD among individuals with normal BMI is increasing. In a recent systematic review and meta-analysis that was published in the Lancet Gastrohepatology, it showed that the global prevalence of NAFLD and NASH in the overweight and obese population was 70 to 75% and 34% respectively. The highest burden was observed among overweight population in the region of Americas. This is a global figure that was showing the epidemiology or the burden of NAFLD and NASH. You could see for the WHO Southeast Asia region, NAFLD in overweight population was about 57%, and in obese population was about 65%. And you can see Thailand is sit as about 62%, ranging from Malaysia 56 to 60%, to very high figure in China, 60%. And also South Korea, a bit lower than the other region, 67%. How about the pathophysiology or risk factor in people living with HIV? It's kind of shared a similar risk factor HIV-negative individual, but there were also some unique characteristics for HIV population. The prominent risk factors include the obesity, diabetes, and hypertension, lipid abnormalities, and some studies also show that a link between the race, ethnicity, or genetic factors such as single nucleotide polymorphism, such as PLA3 gene associated with the fatty liver or NAFLD. HIV may not be associated with NAFLD. From all the cohort studies, they didn't find a significant association with the HIV and NAFLD, but higher NASH and liver fibrosis were observed among people living HIV when compared to the general populations. So there are several risks that are involved with the HIV individual is that the chronic inflammation, of course, immune activation, including microbial translocation, immune reconstitution syndromes, and also a depot tissue dysfunction, which is ranging from visceral deposity, which are very common in people living with HIV, especially among the Asian population, or exposure to the older ERV, such as the D drugs for the mitochondrial toxicity and lipodystrophy. And we all know that some ART will be toxic for the liver, so the toxicity from the ART or metabolic and the weight gain complication from the ART will be characteristic of the risk factor for people living with HIV. And of course, there will be some host factors such as aging, genetic, obesity, insulin-resistant diabetes, or dyslipidemia will play a role. I think David and other panelists have discussed with the association of ART with NAF, but all these data are very premature. We need more data to confirm some of the association because it could be co-founded by a lot of other risk factors. So just give an example in the European cohort that was published last year is that TTF use was associated with the lower risk on NAFLD. If you could see in the hazard ratio was lower for the people who are on the TTF. But at the same time, TAF, INSTI, or the low on the DSCD4 were associated with high risks on FLD. This is the graph that's showing the TAF, and also the INSTI use was associated with high risks on FLD. And you can see the Kaplan-Meier curve is that those who are exposed or who are used to TAF having high risks of steatosis, and also compare with the individual that were on INSTI-based regimen compared with those non-INSTI-based regimen. And in another cohort study, which is done by the SWITCH, a group of researchers using the SWITCH HIV cohort study data, they found that the current use of TAF was also associated with the liver steatosis. This association was prominent among individuals who are overweight and obese, compared to the lean individuals who have normal BMI. There was no significant association of INSTI or TAF with the NAFLD or steatosis development. Regarding diagnosis, management, and treatment, liver biopsy still remains a gold standard, but there's a lot of limitation. For example, the acceptance from the clients, some by error, complication risk, etc., could limit the use of liver biopsy. So they commonly use screening methods for the NAFLD, which include ultrasound, non-contrast CT scan, MRI, or CAP. More recently, the MI-PDFF, which is the proton density fat fraction, is increasingly used to identify the NAFLD. There are also non-invasive serum-based biomarkers for assessment of the fibrosis. For example, FIT4 score, APRI score, NAFLD fibrosis score. Specificity and performance varies in people living with HIV compared with the general populations. And other imaging techniques such as transient elastography and MR elastography may be useful for evaluation of fibrosis in people living with HIV plus NAFLD. This is one of the reports published in the current HIV-NAT reports showing the screening NAFLD or NASH in the HIV population, which is almost similar to the general population, is that they suggest if there's any suspicion of the NAFLD, which involve the HIV infection with type 2 diabetes, overweight, dyslipidemia, lipodystrophy, or persistent elevation of transaminosis, or exposure to D drugs, even long duration of HIV infection. If you suspect that, you could probably confirm with ultrasound, or if not feasible, you could use the CAP to measure the fat content. And they also suggest to use the liver fibrosis, to evaluate the risk of liver fibrosis by FIT4 index. And if FIT4 less than 1.45, it was suggested that the repeated assessment should be done in 12 months. But if it's more than or equal 1.45, it was suggested to use the transient elastography to monitor the fibrosis staging, and also checking the platelets count as mentioned and highlighted by the Dr. Matthews earlier, very important marker for assessment of liver fibrosis. And then repeat the transient elastography if it's more than or equal 7.5. But if it's involved greater than 10 or even 13, suggested to refer to hepatologists and do the HCC surveillance, etc.
So Vin, just go back to the previous slides. With the cap, what the cutoff to diagnose fatty liver?
Right. So there were several cutoff proposed in the different populations. So the most commonly used was a 248, modern liver 248, but there was even higher cutoff was used, such as 268 or even 270. So it depends on the population. In the study that we have done in Thailand locally, we used 248. Right.
Okay. So we have to make sure first whether the patient have fatty liver disease or NAT failure, and then the next step whether the patient have NASH or not, right?
Yep, exactly. Yep. So with that, depends on the FIT4 or liver stiffness measurement, or even liver biopsy proven fibrosis score. You can stratify the risks of NAFLD to low risk, intermediate risk, or high risk, depends on the results. And lifestyle modification was the first step to be suggested among these individuals with the risks, and also weight loss recommendation and potential pharmacological therapy. And also, I guess we will have a plenary talk tomorrow regarding the NASH, so I will leave it to the tomorrow discussion. And of course, the cardiovascular risk reduction and also diabetes care will be very important for individuals with the risk of NAFLD and then fibrosis. So these are the very early stage of using pharmacological treatment or therapy for the NASH. And then because all these data is like kind of premature, and then some of the studies that were proven not to have concrete evidence showing to reduce the liver fat content. So we still need more data to back them up, and especially among the people living HIV, which is different population for using all these pharmacologic therapy for NASH. And the NASH management in HIV were kind of similar to the general population as we discussed in the previously. All these cardiovascular reassessment, also lifestyle modification, and then weight reduction will be critical at the first stage. With that, I'd like to show some of the data from the HIP-NAT cohort that we have in Bangkok, Thailand regarding NAFLD burden, and also some of the association of NASH with the diabetes and cardiovascular disease. So this is the study that we have done in the HIP-NAT aging cohort, which included individuals more than equal 50 years. And then a cross-sectional study with the study period of 2017 to 2018. And we defined the NAFLD based on the radiologically diagnosed hepatosteatosis, which was mentioned earlier, using cutoff of more than equal 248, and the presence of any of the following three conditions, which is the overweight, obesity, or presence of diabetes, or the evidence of metabolic dysregulation. It was defined in the box and in the below, with several risk factors included, including lipids, even the C-reactive protein inflammatory markers. And the population was the age of more than equal 50 years old without excessive alcohol consumption, hepatitis C or hepatitis B co-infection. A total of 319 people live in HIV, 37% female with a median age of 54, and most of them have a very stable CD4 with 98% were virally suppressed. And the NAFLD and NAFLD prevalence were 35% and 38% respectively. And you can also see from the graph on the right, and the cardiovascular disease risk was kind of comparable between the two groups, and also 10-year ESFD score between the two groups. But very interestingly, we found the higher epicardial fat volume among those with the NAFLD compared with those without NAFLD. But the coronary calcium score was comparable between the two groups. And we also, next we identified the risk factor associated with NAFLD in the cohort. We found that BMI, CD4-CD8 ratio, which was used as a marker of immune activation, high ALT, albumin, epicardial fat volume, or higher liver fibrosis were associated with the MEFLD. There's also proposed this MEFLD term. There was several phenotypes which depends on the risk that they have. For example, if they have obesity and a MEFLD, we categorize this as a MEFLD obese. Or if it's combined with the diabetes or MEFLD, we combine with MEFLD DM. And if they have normal BMI, but with all the other risk factors, it could be MEFLD and lean. And the prevalence of these phenotypes were 26% for MEFLD obese, 7.2% for MEFLD DM, and then 8.5% for MEFLD lean respectively. And there's another marker called FibroScan ASD score, which was developed for a group in the UK, published in the 2021 Lancet Gastroenterology Journal, which was validated with the biopsy-proven liver fibrosis. And then basically it was just developed from the FibroScan, which include the liver stiffness and also the CAP measurement combined with the ASD, which called the FibroScan ASD or FAST score. And we calculated this among these individuals, and the median FAST score was 0.28. And NASH with the significant activity of liver fibrosis was defined as the FAST score more than or equals 0.67. And we found that the NASH with significant activity of fibrosis were more prevalent among the people living with HIV with the phenotype of MEFLD obese, and then compare with MEFLD DM, but not with people living with HIV with MEFLD and lean population compared with the counterparts. So if you can see from the graph here, you can see the NASH with the significant activity and liver fibrosis were higher among people with MEFLD overall, and also higher with the different phenotypes, for example, among people with MEFLD obese and DM. But for the lean individuals, it's a comparable between the two. With that, we conducted another prospective study, which included all the individuals included in the HIP-NAT cohort, and look at the association of the NAFLD and the diabetes development. So this is a prospective cohort study, which included individuals more than equal 18 years of age without hepatitis B or C virus infection, or without diabetes at the baseline. Baseline was defined as the first day that people have conducted the transient elastography. And we defined the NASH as the FAST score more than or equal 0.67. The endpoint was to identify the incidence diabetes in the cohort. So we used cost proportional hazard model to estimate the hazard ratios, and the model were adjusted for age, sex, family history of diabetes, the duration of ART, and diagnosing, which is one of the D-drug exposure, time up with the BMI, hypertension, and dyslipidemia. We included a total of 847 with the median age at the baseline 46 years, 43% female, and 28% and 15% have NAFLD and NASH as the baseline. And we found that baseline NAFLD was associated with increased risk of incident diabetes with an adjusted hazard ratio of 2.8. And also combined NAFLD and NASH at the baseline also increased the risk of incident diabetes. So this data or this abstract was accepted at the CRY 2023. So if you happen to attend the CRY next month, please attend this team discussion, which will be discussed about more detailed data on this. With that, I'd like to thank Dr. Anshali and also all the mentors, especially from Kirby Institute, and also the staff at the HIP-NAT for the support. Thank you.
Thank you, Vin. So, any comment or any question from Vin? No, right? Otherwise, we can move on. So Gail, thank you very much. Yeah, so hope you get well soon. So, okay. Okay, thank you. So just move on to Ajahn Turila's case to finish up the case. So I think because of we have limited time, so we will not take a break. So, so we will do it after the end of the section. And also, if you need, or if you are hungry or something, you just grab it and just eat it in the room. It's okay. Thank you very much. So. Oh, yes, yes, yeah, yeah. But yeah, but I cannot see her. Where is it? I cannot see. Oh, yeah, yeah. Oh, yeah, ask her. Yeah, sorry, I cannot see. อาจารย์ได้ไหมฮะ So we have one panelist, Professor Pernjan, in the Zoom. Ajahn Pernjan, do you have any comment on the case?
No, thank you.
Okay. Because we couldn't see her face. Okay. So just would like to ask the audience about the DTG transition in your country. So we expect that all the country have the dolutegravir in the program, right? Or anyone? Oh yes, Maria, you want to give us your experience on that? Yeah, just come up to the microphone. So this is the experience from Philippines.
Hi, I'm Maria Tarcela Glaire from the Philippines, an adult ID consultant. So the Philippines has rolled out BTG, we call it lamivudine tenofovir and dolutegravir combination. We used to be just efavirenz-based combination for years and years, and then in November 2020 we started rolling out dolutegravir in our facility of more than 2,000 patients. We've shifted to dolutegravir of 30% of our cases. We shift based on patient preference and adverse effects from efavirenz.
Do you have okay, maybe we can discuss more. So thank you very much, Maria. So Ajahn, you are ready, right? Oh, it's not yet.
ใครช่วย
Okay.
Okay. Okay, we'll continue for the rest of the three cases I prepare. The first one is about the dolutegravir rash. I think that I confront with the case like this. Usually it have a generalized rash, not too severe, but happen at the end of the first week, something like that. So I would like to share with the panel or the audience that how often you confront with this complication or adverse event or clue to continue or discontinue or how to handle. Someone may have the experience like me about the rash.
So Iskandar, you want to go first?
So not very common at all.
Not very common.
So I think the incidence of certainly hypersensitivity to dolutegravir, as reported in the product insert, is very low. It's less than, I think if I remember correctly, less than 2%.
2% usually they.
So we don't often, I certainly haven't seen much cutaneous reactions secondary to dolutegravir, and the ones that I have seen, they've often been associated with liver function abnormalities as well. So it's a highly tolerable drug.
Yeah.
I haven't seen it very much. It has been, of course, been reported in a couple of case reports, but I guess that's why they've been reported, because they're not very common, and not as
So
common
less than
as you would
2% or
think,
1%.
yeah. In my experience, concurs
Not
with.
too severe.
No, certainly
Will
not
you
too.
change?
Not too severe. The ones that I've seen have been they've been maculopapular, occasionally urticarial, involving and progressive. so required a discontinuation
If
and a
there
switch.
is no mucocutaneous involved, you will still try on, continue it.
Yeah, if there's no systemic symptoms, no liver function test abnormalities,
Yeah.
and it gets better after a period of observation, then
Yeah.
I think you can work through it. Yeah.
This, David made that clear.
Yeah, so that's also our experience. It's very rare, but it's not zero. So we have seen a few
What-
cases. Again, when people start treatment, for instance, with tenofovir, emtricitabine, and dolutegravir, and then you see the reaction, it can also be caused by the other two agents. And then sometimes you are lucky, and if you change the right one and it dissolves, you think, okay, that's the one. But we normally don't do a re-challenge, so we're not 100% sure. But it's very limited in numbers and also in severity. So I haven't seen a severe hypersensitivity reaction with symptomatic effects. So usually you can treat through, give antihistamines, and patients will do well. Yeah.
So I'm sure that David, that you use a branded one, and how about Iskandar? Is a brand or generic DTG? Because I think so sometime, so after we switch from generic, so I can say, so maybe some ingredients on that, I don't know. So but in our practice, so we switch DTG for over than 1,000 cases. I think we have very rare rashes. So it's happened when we use with like rifapentine, but we don't know whether it's from rifapentine or not, but we have to stop for both.
So we have been using mainly branded dolutegravir. Only generic dolutegravir is only coming very soon, within the next month or so. So it's mainly with originator dolutegravir.
I think we have a very solid data from the DTG development program from the original company, but please be reminded that it's a Caucasian mostly. So we are in the Asian country, maybe we learn something. But from the hypersensitive reaction or rash, it's really rare, only less than 1% in the development program, up to only 12 cases in the 1.2 thousand cases that have the HHR, and the median development is around 15 days. And 9 of 12 is used with the abacavir and 3TC. So I think that everyone in this stage agree together that a very rare reaction with the rash with the dolutegravir, and there is no episode in the development program. They say that no episode of the serious rash like Steven Johnson 10 or EM were reported. So we are quite confident about the rash. But anyhow, I have one case to challenge you. This is my lady case, only 43 years old. She was diagnosed since December 2012. That means last 10 years. Initial CD4 is relatively high at 300, 12%. Body weight is 50 kilo, and the HbS and HCV is negative. She's in one of the study, so we have the baseline viral load just only 2.8 copy. And she was on, of course, on that last decade with the TTC, tenofovir, and efavirenz. Everything seems to be go along with her very well. She is a kind of lady, very beautiful, control her body weight at 50. And of course, in June last year, we have to disrupt the TVR or efavirenz base to be the TLD. On that day, at the baseline of the creatinine 0.7, normal SGPT. This is her picture in December, year 2021. You can see she's really quite, really beautiful cases, and take care her dress, something like that, maybe better than the doctor. And after we start our dolutegravir in June, She complained that in the first month she have the mild rash at the leg and the thigh and slight itching, but she did not concern too much. But in the second month, they have the acne-like eruption on her face that it bothered her very much. This is her photo that she showed me that in September 2012, 22. So my question to the panel and the audience, what is your opinion and plan for her skin complaints? The first one is probably from dolutegravir, stop and change it. The second one is unlikely because the development program there is very rare. You have to find out what is she change her cream or something like that. Third is consult dermatologist. Please vote.
Consult dermatologist.
She's very beautiful one, really. Okay, no one changed. Huh? Everyone believes on the data of the DTG development. Second is unlikely. Okay, let's start from the young man. Huh? Who is young?
Well, I must say that I think it's a very interesting case, so thank you for that. And I think that, well, I think many clinicians in the audience will agree with me that skin effects as an adverse effect of maybe medication can be really very important to patients, because we as let's say doctors, pharmacists, we always look at literature and severe symptoms, etc. But for a patient, everybody can see the skin of a person, so she may feel this is a very severe adverse event to her. Yes. And I don't think we should underestimate the impact on let's say quality of life, and maybe sometimes people who are a model, or so that can be very important to them, which may be not as important, well, maybe to me as a person. So I would really listen to the patient, and in this case maybe stop DTG. So I would go for one.
You voted number one.
Yeah, and to see what was going to happen, and if then that would, well, let's say rapidly improve, I would write a case report about it and really inform the medical community about it, that this can happen if it's true. So I think this could be a severe side effect to me, because you explained to me about the case, and so in this particular situation, I would rather stop and see what's going to happen.
Young man.
So we don't. We sometimes have seen a number of cases of acneiform eruptions after patients immune reconstitute. So, in fact, we wrote about this as a case series about 15 years ago. It wasn't necessarily related to dolutegravir, but to antiretroviral therapy. A segment of the population develop very interestingly acne-like eruptions after starting antiretroviral therapy, and they tend to last for several months.
7 months.
Several months.
Several months.
Yeah, several months, and then it stops, or resolves in itself, or requires a bit of treatment. But it's quite interesting because it's something that you don't really expect. And we described it as a case series of about, I think it was about, not very much, about 8 patients who developed specifically acneiform lesions post-initiation of ART. But this is related to dolutegravir. I personally wouldn't stop it. I would work through it. I would treat the acne, get a dermatologist to come in and treat it. Because if you feel that it's related to immune reconstitution, then it's probably, you might have it with another antiretroviral drug, irrespective of whether you stop dolutegravir.
She already treated for 10 years. and viral load is already suppressed with the immune constitution.
Sorry, I beg your pardon. I completely didn't see that. So it's unlikely related to immune reconstitution. Yeah.
So you will not.
I still would
you
treat.
still vote number 3.
I would still treat the acne. I mean, unless it's really,
you
really
vote number
severe.
3.
I would not necessarily stop the dolutegravir because of the acne.
You will. I have the experience last 10 years about the effervescent create the acne eruption. Yeah, like from the immune, from the effervescence. So any comment from the floor? One who want to stop? Okay. She want to stop. And she stopped in September. And this is the last picture on last Wednesday that she met me. She's quite really happy after stopping off the dolutegravir and everything. So it's maybe not common, maybe very rare, but I think it's really important to know that maybe we have the case like this, the acne acneiform eruption from the dolutegravir. I don't know, I tried to search, but I did not, so that's why I show you. Okay, the second case. The second case is another common side effect of the dolutegravir. It's a decrease of the creatinine clearance. This is one patient of my, is 70 years old, and on the GPO-SAT, that means the combination of AZT, 3TC, nevirapine for 8 years. Everything is quite well. Viral load suppressed. Creatinine stable at 1.0. Clearance, calculated clearance is 60.2. In June 2022, last year, in Thailand, we have no GPO-SAT. So we have to change him to be TLD. Well, after, in June, for 3 months, when he come to follow up, the creatinine is rising very markedly from 1.0 to 2.2. Calculated creatinine is 60.2 to 27.3. He have the gout, but his gout clinical is very stable. The uric acid level is still can be controlled. So I think in this room, everyone know that the creatinine rising or decreasing of the creatinine clearance is just only from the organic cation transportation. And it's maybe like we call it a pseudo creatinine clearance depletion from the inhibition of the transportation of the creatinine from the plasma to the urine. In the 2017, there is a literature mentioned that it's very small increase, just only 0.1 or to 0.15 from the first week and remain stable for 1 or 2 years. But in my patient, it's quite different. It's quite very high change. And not only this case, on last Wednesday, I told you that I collect the case. The first group is the clean group. It's on the TVA base, first line drug, and change to be the dolutegravir base. We follow up 3 months. We can see the difference of the creatinine clearance up to 20. If we calculate into percent change, it's between 20 to 29. And the second group in the pink group is from the PI base and change to be the dolutegravir. And we also can see the difference of the clearance reduction from 15 to 21, or the percent reduction is 17 to 23.9, something like this. This is in my hospital, in Thai patients. And this is an example of the photo of my patients. So I just would like to ask the panel that, what is your most consideration to live from the DTG, the baseline age, creatinine clearance borderline that you would not like to challenge with the DTG. The patient have underlying disease like a DM, hypertension, gout, or concomitant drug use. The magnitude of the CCR change after you use it, or the percentage of the CCR change after the use is, the number 5 is all of the above. Maybe someone insists that I do not concern. It's so much. Please. I think this one is the most common side effect of the dolutegravir practice. Someone may call it a pseudo lysine creatinine. Very diverse. Okay, maybe we start from David.
So I think this is an important topic. So again, thank you for addressing this, because I think there's a lot of misunderstanding around this, and this indeed is a very nice picture, especially for me as a pharmacologist, because it really explains what is happening. So I think that many people may not realize that all the time that we were using creatinine, serum creatinine, to evaluate the renal function of a patient, we do not say, but we mean to look at the glomerular filtration of the creatinine. So, and that gives us an indication of the renal function. But in fact, creatinine is the imperfect marker for that, because there's an additional 15 to 20% secretion of creatinine, which is not going through the filtration through the glomerulus, but through this active tubular secretion, as you showed on the other slide. And there's a transporter here, the OCT2, that is transporting the creatinine into the urine. So if you inhibit that transporter by using dolutegravir, it also happens, by the way, by trimethoprim, it happens with rilpivirine, it happens with cimetidine. There can be some oral anti-cancer agents also all doing the same effect. You see an increase in serum creatinine, which has nothing to do with renal toxicity or renal dysfunction. It's just a cosmetic change in serum creatinine. Our experience is that it is usually around 15 to 20%.
15 to
20%, and then it stays stable. So, in fact, you should not look at this change, but you should look 4 weeks or 8 weeks after, and then you have a new set point.
Yeah.
And I haven't seen any case in our clinic for further increase of serum creatinine, other than other causes of renal dysfunction. So I haven't seen any renal dysfunction with dolutegravir above this 15 to 20%. So I think that's important to realize, and do not make the mistake. I must admit, however, that I often hear from doctors in our hospital, they still find it difficult to look at it, because if a patient has a normal renal function, then okay, you can accept this small change. But if you already start with a lower creatinine clearance, and then you have this additional decrease, then you come into an area where maybe you have to adjust doses of other medications, for instance, and you're not sure about the exact renal function anymore. So sometimes I see doctors changing dolutegravir because of this serum creatinine increase, because they find it difficult to evaluate the renal function in such a patient. And the last thing I can say about it is that also something that people do not realize that often is that if you have already impaired renal function, then this contribution of tubular secretion relatively is higher. So if you start with a much lower creatinine clearance, then you can have maybe 30 or 40% reduction, because then the percentage of tubular secretion is larger relatively to glomerular filtration. So then you really run into problems if you see a reduction of 40 or 50% of your renal function, which is already impaired. So that makes it very difficult for people to stay on dolutegravir.
Any more comment?
So I think for this case, we have to think about because he's 70 years old, and also he started with creatinine 1. So if we look at in generally, so if the patient older than 50 or 60 years old, if his creatinine is higher than 1, so it means that his renal function is declining over than 50%. And also with this age, so although the DTG have the effect of the renal the clearance, but the issue is that he was switched to tenofovir as well. So maybe because of his age, he has a renal toxicity from tenofovir. So I think if in this case, I would use a dual drug rather than TLD at the beginning because of the older age. So we would prefer dual drug if the patient doesn't have hepatitis B, and especially switch from viral suppressed, and if the patient, if they are older or lower body weight, so it's high risk of tenofovir related renal toxicity. Yeah, so I would go with dual therapy. Yeah.
Any more?
Yeah, I've had a number of cases like this where a patient with pre-existing probably kidney disease starts on a TLD regimen, and then there is a progressive decrease in creatinine clearance, and people tend to concentrate really on the creatinine clearance without really knowing that there's an increase in pseudo creatinine increase. And I think people then forget, because it's occurred in relation to the initiation of dolutegravir. Even though the patient's been on tenofovir before, we tend to blame the dolutegravir when in fact it could potentially be the actual nephrotoxic drug, which is tenofovir. But there have been some cases where, despite that, they continue to experience progressive increases in creatinine over time. And so those are the ones which we would probably stop. They're not very common, but there have been a couple of cases, and it is often very confusing. So, I would go back to the patient, look for other risk factors for chronic kidney disease, see whether they were contributing to the creatinine increase, maybe perform an ultrasound scan of the kidney, but not switch immediately. Once again, watch and wait, and maybe remove the potential offending agent, which we know is definitely nephrotoxic.
Anyone have more experience to share about the creatinine clearance issue in the dolutegravir use?
I'm interested to know what you did or what you're going to do.
I think that we have two ways. But anyhow, in Thailand now, we are forced. Our patients were forced to use dolutegravir because, like in the social security scheme, they did not order the efavirenz or have the combination of efavirenz base.
It's
so
not,
maybe, if not, maybe I think that for the case that can use the two drugs, maybe we move away from the tenofovir or something like that first. But anyhow, I think we can learn more because we just transition in June. So now it's 6 months after we transition. We have a number of cases like this. Yeah.
Are your two drug regimens co-formulated or they're separate pills?
Not yet.
Not yet. Okay.
Any more share? If not, I will move to, okay. What should not be tried, dolutegravir? Of course, Ajahn Anjali already mentioned, really compromised clearance. And okay, I will, from the DTG development program, maybe it's like David have comment that no grade of the high grade of the clinical increase and lesser than the 1% that have the change of to two grades and change of the creatinine. In fact, it's with the abacavir and tenofovir base of the population of 700, 500 cases in DTG program is not different, really surprising. David, have any comment of this data? No. Okay. Okay, the last case is the third case an allergy patient. The last case is of course a weight gain. After switching in Thailand, we use lopinavir as a PI because it's the very cheapest. So most of the patients after on the ephedrine, and the first line of TVR to be the TLD. Usually we have the increase of the creatinine, decrease of the clinical length. Another problem is the increase of the body weight. This is my female patient, 49 years old. Not too beautiful, but she quite concerned about her body weight. That increased for 5 kilo within 3 months after changing to TLD. And on last Wednesday, she's quite unhappy. The face is very unhappy. Usually she often smiles to me, but this visit she said, why my body weight increased so high. So I would like to ask the audience first, for the case of using of the TLD, reduction of the clinical length, body weight gain 4.5. Will you continue? Yes, it's continue. No, it's not. The patient is unhappy. Really? Both continue and discontinue. Okay. David, will you comment first?
Yeah, I think then when the first data were presented about weight gain, of course, many people started to think about what could be the mechanism behind it. And we already discussed some of these aspects already with some of the previous cases. One thing that could also play a role, and of course it's not to say that I'm sure that's happening here, but if there can be an increase in appetite, so that patients start to eat more and they feel better, and they may not realize that they were not feeling that well when they were using the other medications. They were more nausea and not feeling well, abdominal pain, etc., diarrhea even with the previous regimens. And now they have this agent which is not causing these effects, or maybe even increase in appetite. There are some theories behind that. So that although it could be seen as an adverse event of the drug, so there could be a causal relationship between the change to dolutegravir and the increase in the body weight, there could actually be an intervention by the patient herself without stopping the dolutegravir, but to reduce the calorie intake, to increase the exercise, and of course that needs motivation, and I understand that's difficult, but I think that's something we have to realize. Even if there is a likely causal relationship with the drug, there can still be other interventions than stopping the medication.
Yeah, I think the area around weight gain and integrase inhibitors and TAF is very, very interesting, and I think we're still trying to work through the actual mechanisms, whether it is, whether they're actually weight neutral and you're actually removing drugs which are potentially suppressing weight, and that's why patients gain weight while they're on tenofovir or dolutegravir. I think the evidence with Kaletra is less, but as David said, potentially because of the GI toxicity that can be associated with Kalitra. I think once again it's very tempting to switch to one to offer patients something which involves more than just diet and exercise. And sometimes we find ourselves repeating ourselves again and again, and the patient looks at us as if we should be doing more. But in reality, that's often what should be the first thing and continue to be the main interventions in this area in terms of diet restriction, encouragement of exercise. And there are very few reports of switching from one regimen to another and resulting in a satisfactory outcome that the patient wants. I think, they're emerging, but they're very few. It's often limited to one or maybe two patients within case reports. And I think the guidelines, as it says, whether it's DHHS guidelines or other guidelines, the recommendation is once again to reinforce dietary restriction and encouragement of weight loss, and not to switch unless really there are no options, or if you have other associated metabolic abnormalities developing. So I would be patient, I would reassure patient. I wouldn't switch immediately, no.
They are very concerned when especially some lady, if they gain their body weight of 2 or 3 kilos within few months. I think it's quite a bother. And to talk is easier, to the modify lifestyle modification, but to act is more difficult. Yeah. So anyhow, one of the Win.
Yeah, so a quick question to the panelists and also speakers, that if we want to switch, which drug would you recommend to switch? Because some data showing bictegravir could be having fewer weight gain compared with dolutegravir, or even newer NNRTI such as duravirine. Any thoughts on that? Thanks.
So I think that some study is ongoing, Vin. So look at whether in the patient weight gain from integrase inhibitor, so whether switch to duravirine versus continue DTG-based regimen. So which one is okay? So we need more data to support that. So if we think about DTG-related weight gain, so maybe we can, I don't know, go back to non-DTG-based regimen. And I think, so maybe we should emphasize, like Iskandar says, so I would request them to do intermittent fasting diet. so it's so many good things on many benefits of intermittent fasting, especially for weight gain or weight loss. Even though I practice that, but I haven't seen any weight loss on that. But I think at least I decrease like insulin, right? And also decrease instead of diabetes. Yeah. But for this case, it's quite difficult.
I would like to explain that one of the most common questions direct to me since June, after we transition of the TLD. One of the most questions that patient told me, why I have to change? I'm really happy for 5 years, 10 years. I have no problem, but you told me that this one is better. So I believe you, I use it. But after 3 months, 4 months, I don't think so that it's better. So this is one of the most common points that the patient direct to us. When we often say that we are the patient center, but for this situation, I don't know that. If we ask them, they prefer to back to the previous regimen.
So commenting on your suggestions to change to bictegravir, which may cause maybe a little bit less weight increase, dependent on the studies you're looking at. In our country, it's always bictegravir as part of Biktarvy, and so you always get the tough then component. So that's not very attractive to change for that reason to Biktarvy. We do a lot of changes for weight increase on dolutegravir to doravirine, as we have that available in our country. especially if the BMI is really high already, and then additional weight increase is not something you like to see. But I must say that although we did not really evaluate it, I haven't seen major changes then in reduction in BMI, etc. But at least you can then say to a patient, okay, I changed the medication, that's not making a big difference, now it's your turn. Yeah.
Just listen to the patient.
Just short example. This is a male 55 years old golfer switching from the nevirapine base because of the rising of SGPT, but not too significant, and use of the TTC and dolutegravir. And he gained 3 kilogram body weight within the 2 or 3 months. So I think that just to mention that the weight gain following the ART initiation, we have a lot of data that integrase transfer inhibitor maybe have the impact to the weight gains and also the TAF. And in an advanced study, the mean weight gain change after 2 years with the subject of the 1,000 case in a female have more than 56%, and most of the subjects are the blacks, and in the South Africa we know that the weight gain is allowed for the dolutegravir TAF base is the highest when compared to the dolutegravir non-TAF, and when compared to the previous one equivalent. And so I think the era of the not only the weight gain but the list of the coronary vascular and the diabetes may be our concern, that will we use this regimen with the side effect of the weight gain and maybe have the side effect drag to the cardiovascular list and diabetes list. So I think that the INSTI integrase transfer inhibitor induce a greater weight gain more than the comparator regimen. We are in the era of this one, but in the future we didn't know what to be more data. At least today I just want to share my practice, just only 1 week, about the skin reaction, the renal adverse event of the pseudo decreased gain clearance, the liver enzyme elevation, and the weight gain. So I would like to stop here and thank you for
Thank you very much, Ka. So the next, I just would like to I just would like to ask the question specifically for David. So we receive a lot of questions whether DTG can be taken with any vitamin or any antacid. So I think when we look at the recommendation, so I think it's the patient, it's very difficult to their life. For example, if you're going to take calcium with DTG, and you have to take like a calcium 2 hours after TLD or DTG, or at least 6 hours before TLD. So I think that the patient didn't want to do that because they have to count on the time of take DTG and other. So what would you recommend if the patient want to take, whether they can take DTG with milk or with antacid or with calcium or iron?
Yeah, so that's indeed an important question, and we all know patients do take a lot of cations, and sometimes prescribed by you as a doctor. Sometimes people can just take it over the counter, so many patients are actually taking some of these supplements. If you look at the various integrase inhibitors, because it's really an integrase inhibitor class effect, so it's relevant for all the integrase inhibitors. If you look at all these different recommendations for the integrase inhibitors and the different cations, you can come into very difficult restrictions, sometimes 4 hours, 6 hours, 2 hours. I've always summarized it just to one sentence. Take your dolutegravir, take your integrase inhibitor early in the morning, wait for 2 hours, and then the rest of the day you can take the cations anytime you want. So you take first the integrase inhibitor, and then 2 hours after you can take anything you want, and you separate it over the day. And I must say I haven't seen any major problems from patients not understanding it or not able to adhere to that recommendation. So you just to have to simplify it in the way I just expressed it. I think it's important to also look at indeed multivitamin products, because not always people realize that in the multivitamin products there can be large amounts of cations too. So they don't take it as a separate cation supplement, but it's included in the multivitamin. And indeed, some of the antacids, they contain magnesium or aluminium. And then you have the same problem. There are indeed some data that if you take the integrase inhibitor together with food and then with the cations, then you don't have the same problem. But I'm not sure that has been evaluated for all the different types of the cations, and for instance with dolutegravir. And I consider that still as a risk, that if then maybe sometimes patients do not take the same amount of food and they still take the cation, and then there could be an interaction. So that's normally not a recommendation I give, and that's also because in my experience patients can cope with the recommendation to first take the integrase inhibitor and then wait for 2 hours, and then the rest of the day you can take anything you like.
Okay, that's very good suggestion. And another question. So for the diabetic patient, as we know that the metformin, so DTG increase the metformin concentration. So how important is it in the clinical?
Yeah, so this is a drug interaction lecture now. Well, interesting. I already wanted to say something about metformin, but thank you for bringing this up, because actually the mechanism, if you understand the mechanism of that interaction, is the same as with the creatinine. So metformin is a substrate of this OCT2 transporter in the kidney. So you inhibit the elimination of metformin in the same way as you inhibit the elimination of creatinine. It's the same drug interaction. You see an increase in metformin levels, well, almost half or 1 time higher, so double the exposure, which can be a significant effect. And what we normally say is that you should not give metformin in a dose that is higher than 1,000 milligram a day. And only if you increase that dose, then the interaction may become clinically relevant. If you are below that dose, at least for our European patients, then you can just combine it in that way. Yeah. So there's a maximum of the dose of metformin that you can take. Yeah.
Okay.
The interaction is also there with bictegravir, because it's having the same mechanism, but less strong. So the inhibition of that transporter in the kidney happens less strong with bictegravir.
Okay, thank you. So any comments on this? Okay, so because we have just a time, just a file very quick. So maybe we just go with the last case from Ajahn Pranjan. อาจารย์คะอาจารย์
Yes.
โอเคค่ะ
Okay. So first of all, I would like to thank the organizing committee for let me give some case discussion on the treatment failure in the context of the DTG transition in Asia, efficacy and safety. I would like to start with a female 55-year-old. She was diagnosed of HIV in 2011. Initial CD4 is very low, 24 cells, and viral load is very high, viral load of 755,000 copies. Hepatitis B antigen negative, but she immune to the hepatitis B. Hepatitis C is negative. PDIL was non-reactive. She was start on D4T, 3TC, and efavirenz at that time. Until 2016, ART was changed to tenofovir, FTC, and efavirenz. I think that is because we want to minimize the side effect of D4T to go to the national drug program with the TVR. But there is no information of CD4 nor viral load in the national ART program. So we don't know what is the CD4 and viral load in this patient. Until last year, 22nd of June 2022, she was referred from other hospital, complained with the weight loss and dysphagia. She lost 17 kilograms in 4 months with dysphagia. She said that she have good adherence to ART. Her body weight is only 30 kilograms, Caucasian woman. She has oral thrush, oral hairy leukoplakia, and no lymphadenopathy. Lung is clear, no organomegaly. So I would like to ask the audience, what would you expect on this patient? Clinical failure or clinical with immunological failure? And clinical failure, immunological failure, and virological failure. Please vote. Is it possible to vote from?
Yeah.
Oh,
We
yes,
are conducting.
It's coming ค่ะอา
We
จาร
are
ย์
conducting. Can you
So
see?
most of you said that number C
Number C.
is
Yeah.
all clinical, immunological, and virological failure. Is there anyone want to comment on this?
I think it's obvious.
It's obvious.
Just only surprised why there is some water for the B, A and B.
Yes. So look at the clinical, it's very obvious that clinical failure, immunological, even you don't have the CD4, it should be lower down. And the main cause is the virological failure. Okay? So the CD4 was 33 and the viral load is 6,838. You can see here, the viral load, even she has the virological failure, but the viral load is less as compared to the baseline. The baseline is over 5,000 copies, 500,000 copies, but right now it's only 6,000 copies. So this is because she's still taking the ART. So why the viral load is not so high? So it has some effects. Okay. So what you expect on the genotypic sensitivity on this patient? She on D4T 3TC equivalent and then change to TDF, FTC, and equivalent. Please. A is NRTI resistant with 3TC resistant. B is K65R additional. C is additional with 2 TAM. D is 3 TRAM. And E is Q151M. Please vote. So most of the audience choose B, NNRTI resistant, 3TC resistant, and K65R. Any comment from the panel?
So I think the patient's been exposed to thymidine analogs, lamivudine and NNRTI. So I would expect certainly a degree of NNRTI resistance, probably a KA103N, which is probably one of the most common resistance mutations associated with failure of efavirenz. Invariably, most patients who fail on an NNRTI-based regimen with lamivudine will be 3TC resistant phenotypically. So you'd expect evidence of an 184V. And because of the D4T, it might be that the patient will have TAMs because of the previous exposure to thymidine analogs, which in itself, I think, if I remember correctly, prevent the development of resistance to TDF or the other way around.
Yeah, so I'm not a virologist, so you can ask me anything about drug interactions, but virology is something different. If patients are failing on a tenofovir-based regimen, and we are assuming that she is now failing on the tenofovir regimen that is suspected to take, then the K65R develops. So the question is whether the virological failure may also have happened earlier, and we don't have that information. So it's a little bit difficult to speculate what we're going to see. I think if you do the genotypic testing and then the result usually gives you some explanation of what happened in the past. So I don't think there's a good or a bad answer. So if it turns out to be D with a lot of TAMs, then probably she was already failing on the first regimen, and that continued with the second regimen. So I don't think you can really, well, you can make a guess, and my guess would also have been B, because she's now on tenofovir, and she's now having this clinical symptoms. So if she already had been failing on the first regimen, maybe you would have expected to see something happening earlier than now. But that's all speculation. I think you have to do the test, and then you can construct more or less the history of what happened.
Only my point is that her clinical and immunological stage failure is not correlated with the virological number. In fact, I would like to see more higher viral load, like more than 6,000. Because her clinical is so bad now, have the esophageal candidiasis, have the CD4 very low, up to 3
Yeah.
But the viral load is only 6,000 for me, it's a failure cases.
But what could be an explanation is that you're now looking at the results and the clinical presentation as she is presenting to you. You don't know what happened in the past. So if she had stopped medication for a long time, or she had taken it irregularly, that could have caused the CD4 decline, that could have caused the clinical symptoms. And if she now started or restarted to take some medication, then your viral load will responding to that most directly, and without having a CD4 increase, without preventing the clinical symptoms. So it could be a sign of, well, let's say, more recent adherence to the medication, while she may not have been non-adherent before.
I agree that the genotyping data maybe give more information.
Yeah, so I think he has a long duration of failure because we don't have her data before switch to tenofovir, and maybe she has some TAM, 2 or 3 TAM, we don't know in the past, but switch to tenofovir maybe because of the no pressure effect to D4T. So we might expect to see just only K65R for tenofovir and 3TC resistant, and K103N for efavirenz resistant.
Okay. I agree with the audience and also the panel that we would expect NNRTI failure because she on efavirenz, 2TC resistant because she on FTC or 2TC, which is a low genetic barrier, and tenofovir that she on very long. I would suspect that she have K65R also. Okay, but look at her genotype. She has 3 TAMs and K103N and M84V, which is resistant to many of the NRTI. Here is only intermediate resistant to D4T and tenofovir, low level resistant to ACT, high level resistant to NNRTI except for efavirenz. Now, look at her lab. CBC, she has anemia, hemoglobin of 7.7, hematocrit of 23, white count quite high, platelet is in normal limit. BUN 17.2, creatinine 1.62, EGFR is only 35.48. Sodium low normal 130 and potassium 2.6. Other lab mostly in normal limit, including liver function test. We test the hepatitis again normal. Serum cryptoantigen normal. Urine exam protein 1+ with white blood cell, but she asymptomatic for UTI. Stool exam no parasite. Chest X-ray was normal. What would you give the ART, the second line in this patient? A is ACT, 2TC dolutegravir, TDF, 2TC dolutegravir or TLD, tenofovir FTC and darunavir boosted, dolutegravir with darunavir boosted, or we add efavirenz into the regimen. Please vote. Quite split out, and most of the audience choose number C, tenofovir, FTC, and darunavir boosted. Okay, since we are in the dolutegravir transition topic, and I also prefer dolutegravir. So on July, we start dolutegravir 50 milligram and darunavir 600 and 100 milligram OD on her, fluconazole for esophageal candidiasis and cotrimoxazole for PCP prophylaxis. 1 month later, she come back lost to follow-up for 1 week and missed her ART for 4 days. At this time, we also asked the history of ART in the past. She admitted that she used to miss the visit in the past, but she gained 8 kilograms, no oral thrush. So we continue the same medication on her for another 3 months. On November 22, her CD4 was 100, viral load undetectable. Any comment from the panel?
Yes, so I have a question, well, maybe in general to the audience, because the majority of the people in the audience voted for A, B, or C, which contained dolutegravir, of course, but also continued with the nucleosides, while there was already quite some resistance there. And maybe tenofovir had still some activity, but you also saw the renal function of the patient that was impaired. So also my guess would have been dolutegravir with the darunavir if you have that access to that. So is the reason that not that many people voted for that option because it's not available, so that you have to go to nucleosides and dolutegravir, or what could the other reasons for not going to dolutegravir, darunavir, because she was not exposed to integrase, she was not exposed to a boosted PI, so she had 2 active drugs, and well, you have seen the result, but I think you could have predicted that based on her history.
In my practice for the failure case, I usually explore what is the cause that she create her failure, like a compliance or the complication or drug interaction, something like that. And in her history, the history of drug burden is not so much, only 1 pill, like before it tenofovir, TTC, and efavirenz, which is quite very convenient for her. But why she did not adhere to the medicine. Okay, I agree with Ajahn Purnchan to choose this choice, because most of the dolutegravir and darunavir you can see is 1 pill a day. That may be most convenient for her compliance. And also is the drug profile of both drugs, not only the efficacy, but also the genetic barrier is so good. So maybe one of the best combination right now.
So I'd agree with the nucleoside sparing regimen. It's probably the regimen which is most likely to suppress her viral load because there are 2 completely new agents from 2 different classes. So you'd expect that she would, and she has, suppressed on that regimen. However, this regimen it's quite expensive where we are, and darunavir is not cheap. And so I think it would be attractive I think for the patient, if they were paying for it, to maybe consider an alternative option. I think this, just to reiterate, I think this is the best regimen if you are not paying for the drugs, but if you are paying for the drugs, it would probably be not best for the patient. So, I mean, the other thing, whether you could replace it with a more renal-friendly nucleoside regimen. I mean, her GFR is 35, and TAF, you can use it until 30, but I think it's too close for comfort, so maybe not. Abacavir, we know that I think there was either intermediate sensitivity, but then nowadays with the NAGIA study, although it's extrapolated to mainly tenofovir, recycling of tenofovir and 3TC, whether you could extrapolate, for example, the use of abacavir despite a resistance test saying that it hasn't got much resistance, and I welcome suggestions or recommendations from the audience or the panel. So maybe, but maybe that would be an alternative option as well.
Yeah, and then maybe effectively you may give dolutegravir monotherapy. And that's not recommended, of course, so I'm not going to say that here. But also, if you look at the studies, there was a 60 to 70% response rate in the monotherapy studies after 1 year. So there can be some patients who actually, at least for some time, can be suppressed on dolutegravir monotherapy. So not to say that you're going to do that, but maybe effectively you are doing it even if you combine it with nucleosides.
David, can you comment on the dose of the darunavir 600 and 100 milligram OD for this patient?
Yeah, I saw it already. That's not the normal licensed dose for once daily darunavir ritonavir. That's 800, 100. But well, there's a long history of trials here in Thailand looking at lower doses of boosted PIs, especially in a patient with a lower body weight. So I think this is a perfect dose for any patient with this low body weight. Some people even say that it's a perfect dose for any patients because we are overdosing the protease inhibitors, and maybe even all patients could take 600, 100, but that will never be proven, I suspect, in the future. But for this particular case, I think that's a very good dose. I don't expect you to have access to therapeutic drug monitoring, but if you have, then you can even check the drug level and see whether it is indeed therapeutic. You have to take this medication with food, so that's important for her anyway. If you look at the body weight, so that could also be important to look at the right food recommendation with the medication.
I totally agree with the panel. I do not choose ACT because she have anemia and she have a pre-existing renal function very bad. So I choose this. This woman is, we can get this medication through the NAT program from Thailand. She doesn't need to pay out of her pocket. You already know the WHO recommendation. The first line is the TDF, XTC, and dolutegravir. And if the patient failing the first regimen with tenofovir, XTC, or efavirenz or nevirapine, the next preferred second line is ACT, TTC, and dolutegravir. Vice versa. If you start with ACT, TTC, efavirenz, or nevirapine, the second line would be tenofovir, XTC with dolutegravir. So dolutegravir, it should be the second line for NNRTI failure. And I would like to show you some data that this one is already old data. The Downing study is a randomized open label phase 3 study in resource limited setting. The patient have failed NNRTI for at least 6 months with virological failure. They have at least 2 occasions of viral load over than 400 copies. And then they have to do the genotypic sensitivity and choose receive one active, fully active NRTI, randomized to receive either dolutegravir and lopinavir. This study was already published, and you know that the dolutegravir is better than lopinavir in intention to treat and per protocol study. And if you look at the 3TC resistant, if the patient have M184V or I with other NRTI mutation, you use 3TC or FTC or not use 3TC or FTC again, dolutegravir is bit better than lopinavir. And this is a sub-study. You can see that all of the studies show that dolutegravir is better than lopinavir. Look at this one, WHO recommendation. If you choose the NRTI backbone based on WHO guideline, also dolutegravir is better than lopinavir. And this is already mentioned the Nadia study. This is a multi-center factorial 2x2 randomized open label non-inferiority trial. The patient on tenofovir 3TC or FTC with NNRTI for 6 months and has treatment failure, viral load over than 1,000 copies. The first randomized is to receive dolutegravir or darunavir, and then have a second randomized to receive 3TC TDF, which is the previous NRTI that the patient received, and or change to 3TC ACT. And the same for darunavir group. The 48 result already show that dolutegravir was non-inferiority to darunavir, and 3TC FTC not inferior to 3TC ACT. This slide show the 84 efficacy. Again, dolutegravir and darunavir is no inferiority, but TDF did better than ACT group, did statistical significant. So in this study, even the patient on TDF before, you can recycle TDF. And this is a sub-study between, look at the dolutegravir with darunavir. There is no difference or non-inferiority in this group. But if you compare tenofovir with ACT, you can see here, if the patient do not have K65R, tenofovir did better than ACT. And if no M84V, tenofovir is better than ACT. And tenofovir resistant with none or low, again, is better than ACT. And the last study is the dolutegravir compare with PI-based regimen. There is 2 comparisons. This is the patient on efavirenz or nevirapine with 3TC and tenofovir. They have 2 arms. The arm A is viral load less than 1,000 copies, and then randomized to receive dolutegravir 3TC TDF or FTC TAF. In arm B with viral load over 1,000 copies, they randomized to receive the same regimen as above, and the other 2 is lopinavir with 3TC ACT or atazanavir 3TC ACT, which is based on the WHO guideline. In this study, you can see here, if the baseline of viral load less than 1,000 copies, the DTG FTC TAF compared to 3TC TDF is non-inferiority. But when in the patient with baseline viral load over 1,000, here, dolutegravir arm did better than PI arm for both lopinavir and atazanavir. So to summarize all these 3 studies, in patients with HIV failing NNRTI-based regimen in drowning, with at least one fully active NRTI from genotypic sensitivity at screening. Dolutegravir with 2 NRTI was superior to lopinavir with 2 NRTI. And in the Nadir study, the patient who on failing regimen with NNRTI with XTC and TDF, dolutegravir with 2 NRTI was not inferior to darunavir boosted, and tenofovir was superior to cidovudine. In recent study, NRTI failure with 3TC and TDF, tenofovir, dolutegravir with 3TC and tenofovir was not inferior to dolutegravir with FTC and TAF, but is superior to PI regimen, lopinavir and atazanavir. So come back to our question about the dolutegravir should be the treatment of choice for second-line therapy. Is high genetic barrier, low side effect, low drug-drug interaction, and relatively low cost as compared to protease inhibitor. And patients who fail NNRTI with TDF and XCC regimen should change to dolutegravir. If you have genotypic sensitivity, choose active NRTI. But if you do not have the genotypic, you may use TXF and XCC in the backbone. Thank you very much.
Thank you very much, Ka. Any question or comment from the floor or from the online? Oh, yes, please. Please identify yourself. Yeah.
Hi, I'm Lisa Stevens from FHI 360. I primarily work in the TB world, and I really appreciate learning so much about how we're working with different mutations and resistance and failure. One thing I noticed was missing in your workup, maybe it happened and you didn't mention it, but was screening for TB. And somebody this immunosuppressed, we should be at least getting a lateral flow LAM urinary test, which is inexpensive. So maybe, I know it's not available in many countries in this region, but TB is such a big problem in Asia. Just wanted to mention that. Thanks.
Okay, thank you very much. I totally agree with you.
Yes, 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 please.
So good afternoon. I want to learn about the experience related to Swiss patient on the second line with the lopinavir ritonavir to the TLD. Do you have any patient switching? A patient are using the lopinavir ritonavir have been switched to the TLD before. So I really want to learn about this. Thank you.
Yeah. Ajahn Julie.
Your question is about changing from lopinavir to dolutegravir base, right? When I think this is a similar situation in Thailand and in the Southeast Asian area, because of, in fact, now we know that dolutegravir is a simple tablet. And the price is no issue. I think now it's very cheap, even cheaper than the lopinavir. So if the patient can tolerate, can use, I think that changing from lopinavir to to dolutegravir, I'm agree. But in some cases that I show you that in some cases there's a problem that after we change it, one of the simple one, some of my patients complain of the constipation. After the change from the lopinavir to dolutegravir, we laugh, but in some case it's very severe. They say that mostly is mild or moderate, but I face with some case really severe and they cannot tolerate at all. So I think that there is a little room for not to change lopinavir to dolutegravir. I'm not sure that answer your question or not.
Yeah. Can I just add, I think this transition from PIs to dolutegravir is happening everywhere in high-income settings, low-income settings, where there's access, particularly to generic dolutegravir. Because dolutegravir is, it's a small-sized drug, it's low pill burden, high barrier to resistance. It's a very attractive drug. Compared to Kaletra, I mean, for many, many years, patients had to endure Kaletra as the preferred second-line drug. And particularly for a lot of Asia, which was very, very unfortunate. Kaletra maintained a very high price throughout the region, and patients across the region just got such a bad deal when Kaletra was phased out in high-income settings. So it's good to recognize that patients in Asia got a really bad deal for a long time from Kaletra, and this transition is a good thing. And we have evidence from data that was presented from the VICEN study in patients who are virally suppressed, and also the 2SD study, which was done in Africa, looking at virally suppressed patients who started with a PI and then transitioned to an integrase inhibitor that, when followed up, I think at 48-week data they had, that it was safe and that viral suppression was maintained. So it is a reasonable, a safe, and it is better for patients in the long run. Now, of course, we have the occasional patient who does not so good, which is unfortunate, but I would expect them to be few and far between. I think in Malaysia, we can't wait until we get hold of this generic dolutegravir, which the company has been promising us for at least a year. And patients still have to tolerate Kaletra still to this day as second line, which is unfortunate.
Yeah, so just like to summarize here that dolutegravir is superior to lopinavir. So it's better in terms of viral efficacy, in terms of genetic barrier, and in terms of the side effect and pill burden. But just be careful because of if we use TLD, it's a combination of tenofovir in the case with the renal compromise. So it can increase the problem with tenofovir toxicity. So another fixed dose combination. So it's available just only generic drug. It's a TAB combination with FTC and with DTG. So maybe another scenario to use, or another regimen to be used compared to a TLD regimen. And some patients, because if they use boosted lopinavir without drug resistance in the past, so maybe they can use a dual drug, like darunavir boosted DTG with lamivudine or DTG with ripivirine. So we encourage the transition, yes. And with few, so we have some unfavorable, but it's not that many. So, and it can be manageable.
Can I just ask, is Philippines doing that now? Is there plans to transition patients from PIs to DTG? Yeah. So soon we probably, maybe we'll see PIs gradually being phased out as a class of drug, as patients, more and more patients have transitioned to dolutegravir.
So David, you have any comment?
So that's indeed what we are seeing in Europe too. although I must say that we do have some patients, as in the case that was presented with dolutegravir and darunavir, so we still need boosted PIs for second or third line regimens. But indeed, the large majority is on integrase now, and we don't see, of course, many virological failures that we will need second line after integrase. Well, it's probably going to happen worldwide when integrase inhibitors are being used first line in so many patients. You will see some virological failures, and then you may need a boosted PI in the second line. But I think that's something we're going to see in the coming 5 to 10 years, most likely. So I'm happy we still have the boosted PIs, and we will keep using them. Yes.
So, Ajahn Pochan, do you have any comment?
No, thank you.
Okay. So, any
I prefer dolutegravir. I happy with dolutegravir
Just
transition.
a short comment that though I present a number of the undesirable side effects dolutegravir, it's just only the teaching cases and the warning. But in fact, we change a lot of patients. They can tolerate. And like the panelists comment in the case of the liver toxicity, creatinine clearance depletion, we can learn from the talk that usually is no problem. Finally, you can pass it in the long run. So just try to transition if not so serious problem may be confined to the transition of dolutegravir.
So any comment? So otherwise, so for the tuberculosis, we will have the case discussion more on tuberculosis tomorrow. Just follow up with David. So so very cutting edge on the TB and the dolutegravir regimen, and also so we come to the end. So so today we have learned a lot in terms of how to use dolutegravir and what the side effect, and also the problem with NRTI resistant, how to use it, and the fatty liver disease, and linked to many metabolic complications, and how we can deal with that. So for the fatty liver disease, it's going to be presented in the plenary section tomorrow, right? Yes, tomorrow. So just follow up on that. Finally, I would like to thank our panelists. Okay, so our speaker and all the audience that stay with us up until the final. And thank you very much, and enjoy your day and your night in Bangkok. And please, so I think so we have a coffee break outside. So before you leave, so just get one. So and see you again tomorrow morning. So bye bye now.